Very official. I like it. Thanks, I appreciate it. Thank you all for coming. We're looking forward to hearing from Dr. Farrell. I think he had a busy day. He said he'll be on in just a little bit. Just to start, also, we're glad to be here with the Integrative Med Club. Glad you guys are with us. We can go something together on this. I think this is a good topic that integrates both family med and integrative med, hoping to see additional modalities and things outside of the norm. One quick announcement for ACOFP Club specifically, just a last call for any leadership roles. We've received some great submissions so far, and we'll be putting together the link for voting later. So stay tuned for that so you can vote. And if anyone else wants to apply for something, we would be happy to have you. Additionally, we've posted some things about working with the Huntsman Senior Games. You can find information for that in the Teams page, but I think that'll be a great activity. Looking forward to working in that. And I believe that is all I have in terms of announcements. I'm going to send an email to Dr. Farrell real quick. Hey, Vi. Just got an email from the doctor, said they're asking him for a password to get into this link.
Okay, let me quickly grab it for you.
That'd be great. Thank you so much.
Yeah.
Evan, the link that you sent me didn't require a password, so if you send him the link that you sent me, it should let him go right in.
Okay, I just sent that back, the different link to him. Vi, do you have that? Oh, there it is. So sorry about this, guys.
If you want me to stop and start the recording again when he gets on, we can do that.
Whatever you'd like. I think if it's a recording, people can skip through.
Okay.
First years, how's it going so far? School and all that, of course.
It's going.
Going.
Yeah.
Yeah, MSK, that was a rough one. Whew, don't miss it.
How was your test today?
I actually was out of town for a funeral this weekend, so I'm taking it tomorrow morning. So I don't know. I'm hoping it wasn't too bad because a little stressed for that, but it is what it is, right?
Yeah, Evan, it was just crazy hard, so study hard.
That's what I've not been hearing, but that's how I'm feeling. So
Man, yeah, you'll be okay.
really hope so.
Yeah, it's
Appreciate that boost of confidence. Definitely need it. First years, when is your next test? Oof. It's coming. But then you get to move on into, what is it, MCM? That's a nice thing. Okay. I responded to him with the link and he has not responded yet. So sorry about this. Who'd have thought a year and a half later, we're still figuring out Zoom? That would be good at it by now.
Hi, good afternoon.
How's it going, Dr. Farrell? Glad to have you.
I'm glad to be here. Thanks for having me. I apologize for the tech difficulties. Yeah, this one didn't prompt me for a password, but the previous one did. So
Okay.
hopefully everybody got in that needed to get on. But yeah, welcome. I'm excited to chat with you guys.
Fantastic. We're happy to have you here. So we've got our Family Med Club as well as the Integrative Medicine Club. We're all here looking forward to hearing what you have to say. For the record, Dr. Farrell is living up north in northern Utah currently. He practices up there. He is a family medicine doc, but is also certified in geriatrics and addiction medicine, which is a very cool combination, which is why we're excited to hear from him. We're gonna have a little bit of time where he's gonna talk to us about what his clinic is like, some things he's seen, especially in terms of reducing over medication, being an osteopathic doctor, and things of that nature. We'll have some time for questions at the end, but we're looking forward to hearing from you, Dr. Farrell.
Great. Yeah, I'll give a little bit more of my background. I went to the Toro in Northern California. I graduated, gosh, over a decade ago, it seems now. And then I went straight into, and I went to Toro, California. I don't know if I said that. I think there's only one California now. And then I did my internship at St. Joseph's Hospital Medical Center, which is an allopathic institution in Phoenix, Arizona. And now it's part of Creighton University. And then I transferred and I finished my family medicine at College Medical Center in Long Beach, California, which I'm originally from Orange County, California. And I finished my residency in family medicine. And then I went into practice there for about 5 years, 6 years, in which I was doing home-based primary care. And then I was also a chief medical director for a rather large palliative and hospice care organization there. At which point I was living down there and then really managing sick and complex patients, which you guys will, I'm sure, learn about plenty in the years to come. But even as a family medicine doc, I was a little over my head and managing a lot of these patients. I mean, really end-stage renal disease, end-stage pulmonary disease, end-stage heart disease, all in the same patient. And so then I decided to go back to fellowship or training, and I went back to fellowship and I did my fellowship in geriatric medicine at the University of Utah. And then I stayed on for another year and I did my neurogeriatric fellowship there, of which I finished about 5 or 6 years ago. I stayed on as an assistant professor of medicine at the University of Utah School of Medicine for about 5 years, and just recently transitioned, and I am now the chief medical director of Rocky Mountain Healthcare, which really specializes in post-transitional care programs. I think we're in 7 different states now, but they got their start up here in Northern California. But they have a presence down in St. George and Hawaii and Idaho and Colorado, and so I oversee the overall healthcare policies administration from a chief medical directorship standpoint now with Rocky Mountain. I still maintain very much a 60% commitment to direct patient care, which most of that is in small hospitals and transitional care facilities in a couple of different areas. But mainly my administrative role is kind of overseeing docs and providing geriatrics and neurogeriatric expertise to these other facilities that might have internists or family medicine docs. And so there's in the state of Utah, I know only, I think last number I heard is there's only 18 board certified geriatricians in the entire state, which is pretty low. I know there's none down in St. George, ironically, based on the patient population. And so there's what we call a peg and spoke model, where you have a geriatrician expert that can then kind of oversee and train primary care physicians or physicians that find themselves a little kind of over their head with some of these managed, from these patients. And then, as Evan kind of mentioned, I separately did the addiction medicine fellowship while I was a resident, actually, back in California. So while I certainly do practice addiction medicine and really care about the opiate epidemic, as a geriatrician, it doesn't hit us too much these days. As you can imagine, most older patients, if they had opiate use disorder or severe alcohol use disorder, they often don't get to those 70, 80-year-old mark. But that being said, I still very much, as in part of my community and as in the health directorship standpoint, very much do practice addiction medicine, although I might not have a practice where I have a shingle that says addiction medicine. So that's kind of my basic, and I only bring that up because I saw that as part of the agenda. And I'm sure as future family medicine docs that you guys might be very interested in pursuing that as a career and pathway. And I'm happy to talk to you a little bit more about my trajectory and how I got involved in that and what your practice might look like. But I think I'm going to probably hard stop there, because I find generally the questions are more advantageous than hearing me spiel. But a little bit more about my practice. I do live up here in northern Utah and practice mostly in northern Utah. I have to travel a little bit, but I'm very interested in getting back to my my osteopathic colleagues, which I left. I came up here and I went to the University of Utah, which is an allopathic institution, and prior to doing that in California, I was on the board of the liaison board of the AOA. I was on the board of OPSC, which is Osteopathic Physician Surgeons in California. I've been heavily involved in osteopathic leadership since I was a third-year medical student. And so very much encourage you guys all to do so. And I suspect, based on your clinical interest in these kind of meetings, you also share that interest in health policy and health administration and so forth. And so I'll leave it at that. And if you guys have questions, and Evan, if there's anything you wanted me to particularly highlight or talk about, I'm your guys's for the next 45 minutes.
Fantastic. Yeah, that's perfect. I have one question specifically. You have a couple different specialties from family med, and I know you still have 60% with general patients. Do you recommend specializing from family medicine, or is it just depending on what you'd like to do? What are your thoughts on fellowships and additional training after residency?
Family medicine is, I was a little surprised I chose family medicine. I went in thinking I was committed to doing actually neurosurgery of all things. And then I was a good student. I listened to my attendings and said, hey, go try everything before you even make your decision, before you start having to line up your fourth years. And I thankfully loaded my schedule pretty heavy with the surgical subspecialties and realized I didn't want to do that. Towards the end of my third year, family medicine was one of my rotations. I absolutely fell in love with it. And I loved it because I love everything. And when I say loved everything, I mean, I really like pediatrics. I really liked OB-GYN and even thought of doing OB-GYN as a possibility. And so family medicine is the one specialty that allows you to kind of do all those things. And if you really have a focus and an interest, you can pursue that. As we know, there are OB fellowships for family medicine docs. If that's a pathway that you want to go, if you want to do pediatrics, that makes it a little bit more tough. But to answer your question, geriatrics is kind of like the OB is like, if you're going to practice in it, make it a focus of your career. Now, and that's one of the reasons I chose to specialize in it, is because it encompassed 95% of my patient population. I felt I really needed more training in it. So does family medicine need to specialize? Well, first of all, I tell everybody family medicine is a specialty. GP is not, which I don't know if they exist really anymore, but family medicine is a separate subspecialty. But do you need to subspecialize in family medicine? I think that really depends on your clinical interests, but I think it's important for anybody that's going into family medicine to know that there's an option to subspecialize. If you want to do family, addiction medicine fellowships, those are available to you. Geriatric medicine, for the most part, you could get what you'll be able to treat patients cradle grave with a family medicine residency. But if you really want to be recognized as a specialist in that care, as I tell people, that ask me, well, why do I need a geriatrician? And I don't know if there's anybody of you guys that have kids, but why do you go see a pediatrician? So it's what they do day in and day out. And so I hope that answers your question in terms of, whether specialized or not. I don't think you need to. I think family medicine gives you the broadest and widest scope possible. And that's what initially attracted me to the field, and still very much does. Now, that being said, I haven't done pediatrics and probably, with the exception of my own kids, in 8 years. And you get out of practice 6 months, you can quickly lose your skill set. And so that's what I'm saying, like whatever you end up deciding to do, if it ends up being like you're seeing mostly OB or you're seeing older patients, you might want to consider, specialization, but it's important to know that that is available to you as well as a family medicine doc.
Thank you. That answered my question. Appreciate it. I have additional questions, but I'd like to see if anyone else has any questions.
Yeah, I have a quick question. In the past, before medical school, I worked in an addiction treatment center. So I've seen a lot of the modalities of treatment in that regard. And so I was just wondering what kind of your osteopathic perspective is, because I haven't really seen that. All the docs I've worked with were MDs.
Yeah, that's a super good question. I'm glad you asked it, Carson. So I believe an osteopathic approach to addiction medicine is, I don't want to say the only way, but if you're not practicing it, in some regards, in my feeling, it's kind of malpractice. I'll tell you what I do. I mean, I don't do a lot of hands-on osteopathic manipulative medicine in addiction medicine, but where the training I got in medical school, where you guys are now, that I think differentiates me from my allopathic MD colleagues is, and I hate to use the term holistic, and I still haven't figured out since as a first year med student how to choose a different word, but I absolutely approach the care of a patient, particularly with addiction issues, from a 360-degree viewpoint. And I often find that other colleagues, whether it be PAs, NPs, MDs, are focusing, or I hate to use the term myopic even, just on that disease process, and forgetting that the history onto how a patient came in front of you in a rehab facility like you're experiencing, Carson, is something that as a DO, I think you're going to be substantially more trained and equipped to manage. And by that, I mean, it really matters about their social history, right? It matters about their family dynamic growing up. It matters about their siblings and their experiences through high school and college. Did they finish college? Did they not finish college? Why? All these questions about, how a patient kind of arrived at you. And then subsequently, from an addiction standpoint, what is their social network and support system that currently supports or enables them or disenables them, is, I believe, a part of my training that I've seen others not necessarily pay attention to, that I think makes you a better doc. Good question though, Carson.
I have a question. So you'd mentioned that you, as you're going through, you felt like you weren't prepared to handle like really complicated questions or complicated cases, right? Of these older people that had all these various major complications combined together. And I'd heard from other people as well that sometimes family physicians, like they're well trained on preventative medicine, but not as much on the complicated cases. So what do you feel is the best way for, if we choose to go to family medicine, what's the best way for us to get exposure and experience of learning how to manage those complicated cases? Is it through doing geriatrics or other subspecialties, or what would be the best way to get that training and knowledge?
Yeah, I mean, it's a good question. Geriatricians are often called complexivists for that kind of same reason, is that I don't necessarily want to say I felt inadequately prepared, but based on the practice in which I found myself in California, which is a little complicated, like how complex these patients really were. I mean, in first of all, in a family medicine's doc's defense, I don't think an internist is necessarily any more equipped to manage the patients that I was managing. For me personally, there was also a big neurological component that I was always very much interested in neurological diseases, particularly in cognitive disorders. And that's one of the reasons I felt ill-equipped, because you get no experience as a family medicine doc, zero, right? I mean, no cognitive disorders training really outside of your typical psychiatry rotations, which is insufficient. So that's one of the reasons I decided to pursue additional training. In terms of figuring out how to place yourself best to manage the type of patients that I was experiencing right out of residency, I think that's more of a choice of finding the best training programs. I've been at different institutions and different programs, and I think if you do your due diligence and make sure you find a program that really offers you a wide breadth of opportunities while at the same time offering you the type of experiences that might be more aligned with what your interests are, whether it be integrative medicine, whether it be geriatrics, whether it be OB. For instance, if you go and you're interviewing at family medicine programs and you're interested in potentially doing OB in a rural area or even in an urban area, and you want to manage OB-GYN patients, and you're interviewing at a place that has zero OB-GYN, or they have a coexisting OB-GYN residency, it's probably not the best place for you. So it's probably stuff to keep in mind a little bit further down the road. First of all, what is my audience here? First, second years generally, is that right? Okay. So you guys got some time to really further elucidate that. But I think it's about finding the best program that aligns with your clinical interest. And then once you find what that is, can make sure that the program that you're going to facilitates that and encourages your growth in that direction, because you should have quite a bit of latitude in a family medicine program to explore your interests, whether it be addiction, geriatrics, peds, OB-GYN, health policy, administration, etc.
Thank you.
Good question, though, Wayne. So can you guys kind of tell me, I don't know much about RVU. Have we graduated a fourth year class yet? I think we have, right?
Yeah, so we're an extension of a Colorado school. They've been they've been around since 2008. Southern Utah specifically graduated its first class this last year.
Okay.
And so we
How many
are
people were in
mostly
that
here.
first class?
What was that?
How many people were in that first class?
I believe 120 something, and fairly good residency placement, good match. With our school, our rotations are spread out over Utah. Some are up north Salt Lake, Utah County, and down here as well. So it's been great. Really enjoyed it so far.
Cool. It's not a bad place to have to go to at least your first 2 years of med school. And if you can hang around for your third and fourth. Don't underestimate that in terms of where you guys choose to go to residency, and a lot of people won't tell you that, but keep lifestyle in mind wherever you end up going. Most of us going into family medicine, you can generally choose where you want to go. But obviously, as you get more competitive, a lot of people don't necessarily think about that. And if you go somewhere for 4 years, like Buffalo, and you're going to be miserable, and I hate to use Buffalo. Sorry if anybody's from Buffalo here, where you don't otherwise know it. And trust me, I've seen it in retrospect with a lot of my colleagues. It doesn't matter what you go into. If you're miserable for 4 years, you're not going to be very happy as an attending, and definitely going to contribute to burnout sooner than later.
Yeah, it's been nice. Really happy down here. I have another question for you, if that's okay. You talked a little bit about policy. In your perspective, with what you've seen, where do you see family medicine going in the next 10 years? Do you see it changing? I know there's a lot of worry with mid-level creep of NPs and PAs stepping into more of those primary care roles. What is your perspective on the future of family medicine?
Good question. Where do I see the future of family medicine? So I still believe that there is no replacement for physician-led level of care, and the family doc is going to be, in my opinion, continue to be highly solicited and sought after in whatever market it looks like. Now, we hear there's some pretty attractive, and I hate to say attractive because they weren't attractive to me, but a lot of people are looking into, DPC, direct primary care models. There's concierge types practices, but at the end of the day, your 7 years of training as a physician and specialty care and family medicine will never be displaced, in my opinion. In terms of where the future might go, I think you also hit a poignant term, Evan, that as leaders, if you guys have leadership interest and experience, I do see family medicine as shifting more into, I don't want to say administrative roles, but into medical directorship. So, it kind of like the geriatrician as a peg and spoke model, right? I mentioned that there's only 18 geriatricians in the entire state of Utah. Wyoming has none, from my understanding. Idaho's none, I don't think, right? So, if there's only one of us, yet lots of family medicine docs and lots of internists, they're going to be ultimately looking for your, leadership and guidance, and you need to be able to learn how to manage teams effectively. So if you don't have training or experience in how it means to work in an interdisciplinary model, now's your time to really kind of start facilitating some of those interests. I went and got my MBA degree in right after residency, mainly because of my experience with AOA and health policy, and they had me in Washington all the time, and I realized I had no business experience whatsoever, which I'm sure a lot of you guys that can resonate with. But to be able to speak intelligently amongst our colleagues in health policy and health administration is going to be a tool and a feather in your cap as a family medicine doc. I do think as more and more advanced practice clinicians come into the field, I see them dealing with more of the run-in-the-mill urgent care kind of stuff you might not necessarily want to see every day, but that means that the acuity and complexity of the patient that you're going to be seeing is going to be going up. So make sure you have comfortability with managing the sicker and more complex patients, because that's generally how that goes.
Thank you.
You've mentioned
I'm sorry to interrupt. I do not think, for what it's worth for you guys, that there should be consideration given to reducing the time to be a family medicine doc. There's been some discussion about doing a 2-year residency or doing a 6-year combined program, which I know do exist. And there's ways to do that if you know day one you want to go into family medicine and kind of shorten some of the medical school curriculum. And I get those 6-year programs. But there's been some discussion about kind of cutting down the residency program. And from my retrospect, I think I would just gave you a real good example of why we shouldn't reduce residency time for family medicine, in the sense that I didn't feel adequately exposed in a 3-year program. And so if you go to 2, I think now you're starting to really blend and get a little bit closer to, hey, what differentiates a 6-year program from a 3-year PA program? I think it gets just a little closer to that than what it's worth.
You mentioned that you are one of a handful of individuals that have kind of focused more on the geriatric population. What unique experiences working with that population have you learned?
Yeah, good question. So I found myself in a practice that really kind of focused on the older patients in California. And truthfully, I just enjoyed I enjoy working with them. They're, as the World War II generation starts moving on from us, I see a lot of VA patients. They're just really a pleasant group to be around. And when you're enjoying the patients themselves and the banter and the talk and the experiences, it sure makes your job a lot easier. And so that was an easy, and then I love the clinical challenge. The cognitive effort that goes into managing patients that might be on 25 different medications and have problem lists that are 40 or 50 long, take a lot of time and a lot of management, a lot of hand holding, a lot of TLC, and a lot of conversations, a lot of meetings. Whereas if you're seeing your 35-year-old for Ambien refills once a year, it's just a different patient population. I just enjoyed the working, and invariably you have much more exciting, fun patients, and they're overall more appreciative and pleasant, and that just kind of makes the job a lot easier.
So it sounds like you're pretty involved in like an administrative role. And for those of us that are interested in doing what you do, as far as having some administrative stuff, but also primary care, what advice do you have that you wish you had known 7 years ago when you were in med school of how to prepare for that?
Good question. There is a, I'm going to have to check the name on it because it's changed names, but I actually did what I called the mini MBA program. And through the time, I can't even, I'm blanking on what the name of the group was, because I was a 3rd-year med student by the time I started the program. So this is not too far off from you. It's now called the American Association for Physician Leadership, AAPL. And at the time when I was a 3rd-year medical student, they had what I called a mini MBA program focusing on healthcare administration. So it was neat because I was I don't know if they still have hour restrictions, but when I was a 3rd year, we used to do 36-hour shifts in the hospital. So there was some serious downtime there, and I actually finished the entire program before I finished my 4th year. And so that gives you some very specific, targeted business and health policy related training that you can get online, generally at a substantial discount for medical students. I don't know what it is now. But that is one thing that you guys can be doing in the next couple of years. And if you want to kind of the feather in your cap to really get some formal training, just like you, I do think an MBA was overkill for me. I don't think I needed that at all. And unless you really wanted to go that direction, but that's the dark side. But I would encourage you to get some training. If you have some time in the next couple of years, over 4 years, you can do quite a bit online. And then, Wayne, to kind of further answer your question, seek out those experiences and leadership opportunities. And then not only throughout your med school, you know, by heading committees and groups, but even at every level of osteopathic leadership, even in the state of Utah, or I don't know where you're from, Wayne, but are actively recruiting for medical student participation. So don't be shied away thinking that you're a first year med student or second year med student in terms of even throwing your hat in the ring as a medical student leader at the level of your association, your state association. Because I was a third year med student in California and as a liaison to the board, and it was really exciting. So you kind of putting yourself in those opportunities, at least from a health policy, and our osteopathic community is a small but tight one, believe it or not, although it's growing really significantly. They are always looking for medical student participation. And then on a bigger scale, from hospital administration, leadership, and so forth, you know, it's about putting yourself out there and soliciting and looking for people that have experience, that are willing to let you tag along. And then if opportunities present themselves relatively early in your career, for instance, being a chief resident at your residency program, plenty of opportunities, like I said, even in your 4 years of medical school, to be in leadership at different organizational levels, is ultimately how you kind of work your way up that ladder. But by no means, under zero circumstances, expect just because you're a physician, you're going to be given those opportunities. Or if you go to advanced training and do an MBA or an MPH or an MMM, no, they really are looking for the proven leaders that have demonstrated a long commitment to interest in serving others.
Good, thank you.
Mm-hmm.
So we've got just a couple minutes left. A lot of the second years have to head out for a meeting on campus. Does anyone have any other questions or anything else before we wrap up?
While anybody's thinking, I'm happy to continue to be involved, Evan, and you've been great about reaching out to me, and I'm happy to answer any questions. Follow up as an email as well. If you'd like to give any of the group members my email address, please feel free to share that information. And I'm happy to be a resource to you guys. I hope to maybe see some of you in your third and fourth years. I'm working on maybe serving as a preceptor for some of you guys. I miss teaching med students. I've been teaching residents and fellows for 5 years, and so I'm looking forward to getting particularly back to my DO colleague roots, because it's a family to me, and you're going to experience that throughout your career and training, particularly if you stay heavily involved in the osteopathic medical community, because it's a good group, and we stick up for our own, and certainly provide opportunities for our own. And I think now with the ACGME kind of conglomeration, we used to, when I was in training, we had the 2 separate residencies, and I think you could still stay, you know, attached to the osteopathic community longer throughout training. Whereas nowadays, I don't know how that looks anymore. So you might only have a few couple of years to get involved at AOA or at your state association levels or through SOMA, right? Before you may kind of go into a residency program in which the differentiating factor between a DO and MD is non-existent.
Well, thank you so much. We really appreciate you coming. I'll definitely forward your email. I'm interested in going into geriatrics, and so I am very hopeful that I can work with you years 3 and 4. But we really appreciate it. Thank you so much, everyone, for coming, and hope you have a great rest of your day.
Great. Thanks, everyone. Have a good one. Feel free to reach out to me.